So thanks to everybody who signed up and is joining me for the webinar today. I'm really excited to talk to you all a little bit about fertility preservation, egg freezing, embryo freezing, and any questions that you might have related to that. I find this to be a really exciting topic to talk about. It's something that I spend my time every single day, speaking with patients about and doing these treatments, but it's becoming more and more commonplace, which is wonderful. I think there's a lot more awareness about fertility preservation, the benefits out there, and so we see a lot of people that come to me who they had friends or family members that went through this experience, and that kind of inspired them to learn a little bit more about it and decide if it's something that they feel like is something that they want to pursue. And hopefully this will this conversation today will help to give you exactly that kind of information. A lot of this is just that education, that understanding of what this process looks like, who can benefit the best from fertility preservation, and then that'll help you think through if this is something that makes sense for you to look into a little bit further. As I mentioned a few minutes ago, there is a question and answer box in the bottom of your Zoom screen. So if at any point during the talk you have a thought or a question that comes up, please just put it into the question box there, and that'll come over to me. And that way I'll make sure I can spend some time at the end of the talk going through any of those questions, or if there's anything you just would like me to go through in greater detail. And we'll probably end up spending 30, 45 minutes today, going through this information. So, all right, I'm going to go ahead and share my screen here, and that way you'll be able to see. Let's see if I do that. Okay. All right. Hopefully you can see that okay. So for those of you I don't know, my name is Dr. Romanski. I'm one of the reproductive endocrinology and fertility physicians, or REI physicians, here at RMA of New York. As an REI physician, I'm a board certified REI and a board certified OBGYN. And the vast majority of what I spend my day doing is speaking with patients who have infertility and help them to build their families. And the other half of my patients are patients who are interested in egg freezing and fertility preservation, which is exactly what we're going to talk about today. You can see, I have a lot of different roles here at RMA. Number one, I obviously am a patient care provider. That's first and foremost. But number two, I'm an assistant professor at Mount Sinai, and so I spend a lot of time educating the medical students and residents there. And I'm also the program director, associate program director for our REI fellowship here at RMA of New York. So education, kind of like this talk we're doing now, is a very big part of what I do every day. And then research, is another very large component of what we do as a practice. And I help to direct our research efforts here, both in New York City and also with our network practices around the country. So we'll be talking today about egg freezing, and I always like to start this conversation out by explaining the rationale behind this, why we're having this conversation to begin with. And I think that starts with understanding how the ovary functions, because the ovary, of course, is where all of the eggs are stored. When a female is born, they're born with all of the eggs they're going to have throughout the remainder of their reproductive years. After birth, there's no new eggs that are being generated. And so what happens over time is that there's a reduction in both the number, but also the quality of the eggs. But those two things are completely separate entities. And so that's very, very important to understand. When it comes to the number of eggs, when you're born, there's about 1 million eggs remaining in both of the ovaries. Well, by the time you get to puberty in sort of early teenage years, there's really just 1 to 200,000 eggs remaining. And then at that point, once menses begin, there's about 300 to 400 eggs that are lost from the from the ovaries every single month until the time of menopause, which occurs at around an average age of 50, 51 in the United States. And at that point, there's very few eggs remaining. So I always, tell folks that, especially somebody that has regular menstrual cycles, that person is ovulating an egg every single month, regardless of how many eggs are remaining in the ovaries. So you hear a lot of people really focus and worry about that ovarian reserve, the number of eggs that they have remaining. But the important thing to know is that it doesn't really predict fertility at all. I could have a patient with very, very low ovarian reserve and somebody with very high ovarian reserve. But as long as they both have regular cycles, they're both releasing, one egg every month. And so those two patients, if they're the same age, have the exact same, chance of conceiving. But the ovarian reserve is an important number for us to understand a little bit when it comes to reproductive health, and a big part of it when we're talking about doing fertility preservation treatment. Main reason is it predicts how many eggs somebody can retrieve or freeze from an individual treatment cycle. The more eggs somebody has, the more eggs I can get out of the ovaries at the time of a retrieval. And that's really the main evaluation that is done for somebody who's interested in doing egg freezing, understanding how many eggs are remaining in both of the ovaries. And so this usually occurs just with one, visit to your, REI physician's office. They'll talk to you about your medical history, your reproductive history, make sure that this type of treatment makes sense for you to pursue. And then they'll do some blood work and they'll do an ultrasound. On the ultrasound, what I'm looking for is the location of the ovaries. This is how one of the ovaries appears here on an ultrasound. And the main thing I'm looking at is the number of these black circles. We call these antral follicles. So the number of these follicles that appear on both of the ovaries, that is what correlates best with someone's ovarian reserve, the number of eggs that they have remaining in both of the ovaries. It's important to know that within this ovary, there are tens of thousands of these follicles. Most of them are microscopic, they're immature, and they're located in the middle of the ovary here. But every month, the ovary recruits a cohort of them to start to develop, they enlarge, and these are the ones that we can see, these 10 follicles here on the ultrasound. And only when they get to this size can they be stimulated, can they be retrieved. And so the more eggs somebody has, the more of these follicles that develop any given month. And that's why the more eggs that we can retrieve from an individual treatment cycle. These follicles also produce a hormone called anti-Müllerian hormone. And this is something that we can check in the blood work. So that's the main thing that we're looking for when we draw blood at this visit, is what that AMH or that anti-Müllerian hormone level is. And using that follicle count and that hormone level, we can give somebody a pretty good idea of how many eggs that they can retrieve from an individual treatment cycle. So that's kind of the main thing that we're looking for there. Somebody has really high ovarian reserve, maybe they can reasonably expect 10, 15, sometimes more mature eggs from a single cycle. Somebody with lower reserve, we might be looking 3, 4, 5 eggs from a cycle. So this is the part that's very individualized, very different between one patient and the next. So that's the quantity, that's the number of eggs that we're talking about. But what's also important and separate from that is the quality of the eggs. Because just like as time goes on, that number of eggs declines, the quality of the eggs does too. I always tell people that, the eggs you have in your ovaries right now, however old you are, that's how old these eggs are. So a 35-year-old patient, the eggs in their ovaries that we're trying to retrieve and freeze, they're 35 years old as well. And what happens is, as time goes on, these eggs are just single cells, so they're a little bit fragile. And though the first few decades of life, their quality is very stable, eventually the DNA within them will begin to degrade a little bit. And a higher proportion of them over time become chromosomally abnormal. And that's really one of the main causes of infertility that we see as people increase in age. And it's the main reason that somebody would undergo this fertility preservation process. The idea is, if we can remove eggs at their current quality, if that person has infertility or difficulty getting pregnant in the future, once their egg quality has declined, they're going to be much more successful having these younger, healthier eggs frozen that we can fertilize, rather than trying to retrieve eggs and fertilize eggs at that time with those lower quality eggs. And this is a figure that depicts that a little bit. So this is a chart of a bunch of patients that went through IVF, made embryos, and then biopsied them to see what percentage were chromosomally abnormal. It's stratified by female age here on the bottom. And what you can see is that, in the late 20s, early 30s, that's when the abnormality rates are at their lowest. So that's really when egg quality is at its peak, at its best. That stays pretty stable until about age 35, 36. You can see that decline begins at that point. And then every year after that, it becomes more and more significant. So when we think about, when is the ideal time to freeze eggs, ideally it's late 20s, early 30s. We can always freeze eggs at a younger age. There's no reason we can't do it at 22 or 25, but the earlier we do it, the greater chance that that person's never going to end up using those eggs. A lot of those patients maybe will end up trying to get pregnant and be successful in their late 20s, early 30s. And so that's kind of the main reason, to consider maybe not doing it at such a young age. But really that risk benefit of doing the procedure and likelihood of needing the eggs kind of comes to a maximum right around age 30, 31, 32, shortly before that egg quality begins to decline. And that's the time that I really counsel most patients. If you're not immediately planning to conceive in the next 12 months or so, and you're in that age range, that's a really good time to think about maybe I should be putting some eggs away for the future. And part of that decision is individualized based on what somebody's family building goals are, how many children they want to have. Certainly somebody that wants 1 or 2 children is different from somebody that wants 4 or 5 children. And the age that they're beginning to build that family, might make that realistic or a little bit more difficult. And so those are things that we talk about and think about in terms of trying to figure out, what would be a good age to do fertility preservation for somebody that's thinking about that. So hopefully that makes sense a little bit. So that's a little bit of the background about why we freeze the eggs and where that benefit might be. So next, I'd like to transition, to talking a little bit about what this actual treatment looks like. So you have some idea of what that might be. Once you've come for that initial visit, you've done an ultrasound, you've done the blood work, we know the ovarian reserve, we know how many eggs can be expected from a cycle. At that point, somebody could really schedule this treatment whenever works well for their schedule. Some patients want to get started right away, and we'll start, just a couple of weeks later. Other people want some initial information, and then they'll think about it, maybe schedule it for, a time that works well for their work schedule or their social schedule, and then we'll put it off for, a few months or however long is necessary. But once it's time to begin the treatment cycle, this is kind of a rough timeline of what this looks like. And so, it's about 2 weeks of treatment. Usually it starts, here on the timeline where it says stimulation. This usually occurs, when somebody gets their period. That's when we're typically starting these cycles. The stimulation lasts for about 2 weeks. We'll talk in more detail about that. 2 weeks later, once those eggs are ready to be retrieved, the last injection that somebody takes is called the trigger injection, followed by the egg retrieval, and then freezing of those mature eggs, and then the recovery, which usually is pretty quick within a couple of days, but definitely a week or 2 later, by the time somebody gets their period, they should be feeling, pretty much back to baseline. So getting into this timeline, with a little bit more specifics, once someone's ready to begin the cycle, like I said, they'll usually come into the office on the 2nd or 3rd day of the period. That's an ideal time to begin stimulating those follicles to grow. At that visit, we'll repeat the ultrasound, repeat the hormone levels to confirm those follicles look ready, nothing has changed, and it's a good time to get going. And then at that point, the treatment begins. The treatment starts with a medication it's a hormone called follicle stimulating hormone. And it's actually the exact same medication that the body makes every single month at the beginning of the cycle. Usually, the body makes a very small amount of follicle stimulating hormone with the goal of recruiting one of those antral follicles to become the dominant follicle that then will ovulate in that cycle. But obviously for egg freezing, we don't want to just retrieve one egg at a time. That would be very inefficient. We want to retrieve as many as we can do so safely. And so with this treatment, I just am giving you a much higher dose of that follicle stimulating hormone. It's given as an injection. It's a small subcutaneous needle. So this is something that's injected into the abdomen every night. Like I said, that's done for about 2 weeks. It's about how long it takes the follicles to grow so that the eggs inside can become mature and then can be used in the future. During that 2-week period of time, you have to be closely monitored because you're taking this hormone. I need to make sure that, well, number one, you're responding well to the medication, and number two, that you're not over responding to the medication. So that usually means you might be coming into the office every 2 or 3 days for blood work and ultrasound visits. And that's so I can, again, monitor how you're responding. And occasionally I'll make adjustments to the dose of the medication as the cycle goes on, sometimes increasing or decreasing the dose to keep everything well controlled. After about 2 weeks, once those follicles look large enough that I'm anticipating the eggs inside are going to be good quality mature eggs, at that point, you'll take the last injection, we call it the trigger, and I'm going to move my screen a little bit because the sun is starting to shine through. The goal of the trigger is actually to allow those eggs to become mature, which is a very important step before we retrieve the eggs. 2 days later, you come back to the office for the retrieval itself. Now, the retrieval is done in the operating room. We're going to talk a little bit more about how that goes, but it's a quick procedure. You go home the same day, and then we freeze the eggs that particular day. To give you an idea of what these ultrasounds look like and what these eggs look like during the cycle, here's a few different pictures. Again, this is similar to the picture we looked at earlier. This is an ovary, how it appears on the ultrasound, and you can see these small antral follicles. So this is what the ovary and the follicles look like when somebody is first starting their treatment cycle. And again, that follicle stimulating hormone, that medication you take, the goal is to get all of these follicles to grow. And so when somebody's coming back in the middle of the cycle, this is more like what the ovary will appear like. With these follicles starting to enlarge. They're filling with fluid. There's lots of different molecular signals going on within this particular follicle, and that's supporting that egg so that it can continue to grow and become competent. Once the eggs are retrieved from the follicles, then they look like this. This is what the egg looks like under the microscope, and this is exactly what's frozen so that in the future we thaw this and we fertilize this particular egg to make an embryo. So the retrieval itself looks something like this, and this is necessary in order to get the eggs out. The retrieval, as I said, is done in an operating room. It's done with an anesthesiologist. That's important to know that you're totally asleep, totally comfortable for this kind of procedure. It's just anesthesia through the IV, so it's kind of like Twilight, but you are very much asleep and comfortable. The procedure itself is all done vaginally, and that's what this is depicting here. This is showing, this is a vaginal ultrasound probe, like you may have had a vaginal ultrasound before, same exact thing. And we just put a small needle right on top of the probe. And under ultrasound guidance, that is guided into each follicle, and you can actually see that on this ultrasound picture, that needle in one of the follicles. And we use that to drain every single follicle, and we get the eggs out of the follicles in that way. Of course, we drain all of the follicles on both of the ovaries, so we get every single egg that we possibly can. And this procedure itself takes about 20 minutes, so it's actually pretty quick. After the procedure is done, you'll recover, you'll wake up over about 30 to 60 minutes, and then go home that same day. So kind of every day leading up to a retrieval, usually people are feeling pretty well. Some people go through the whole stimulation feeling completely normal. Other people are a little more sensitive to the hormone changes, might have some bloating, some abdominal fullness, but definitely able to go to work and do most normal activities. And then it's just the retrieval day that you'd have to kind of take off of work, take it easy because of the anesthesia, the procedure. You'd be pretty tired for the rest of the day. So you just go home, kind of relax that day. But then by the next morning, most people wake up feeling, like they can kind of ease back into their normal routine. Definitely, get back to work, get back to activities. May have some cramping and bloating for a couple of days, but most of that will subside within 48 hours. And each day, is kind of more and more gradual improvement there. by the day after the retrieval, we know exactly, how many mature eggs were retrieved from the eggs, and how many were frozen. Before, somebody goes home from the retrieval, they know how many eggs were retrieved. And then not every egg is going to be mature. Usually it's about 70 to 80% of the eggs are what we call mature. And then a mature egg is one that can be fertilized in the future. So that's why that distinction is important. So it's the mature eggs that we freeze and that you have available to use down the road. Overall, this kind of treatment, is very safe. There's a few 100,000 of these types of cycles done in the United States every year, but every procedure has some risks. And so these are some of the important things to be aware of. Number one, with the stimulation, there's something called ovarian hyperstimulation syndrome, OHSS. This can occur if somebody has a really robust response to the follicle stimulating hormone, if there's too many follicles growing. On one hand, that obviously sounds great. Each follicle has an egg. The more follicles we see, the more eggs we can get. But on the other hand, if there are too many follicles, what happens after the retrieval is that patient will start to develop dehydration and electrolyte imbalances. And on the severe end of that spectrum, some patients even have to be hospitalized for close monitoring until this resolves. So obviously, this is something that we do everything we can to prevent, to mitigate the risk of this from happening. And there's many different things that I can do in order to keep this risk as low as possible. Those are certain changes to the stimulation protocol, certain ways that I monitor the patients with ultrasound and with blood work. And then that's the main reason for those frequent visits during the stimulation itself, so that if it does look like somebody's over responding a little bit, I can just decrease the dose, keep everything well controlled. And ultimately, this occurs less than 2% of the time, so it's pretty uncommon. The other risks that are important to know about is with the retrieval itself. Using that needle to retrieve the eggs, there is always a risk of bleeding or infection afterwards, but that occurs less than 1% of the time. So that's also quite rare. And then with the medications, everybody always asks, how am I going to feel during the stimulation? What are the common side effects to the medications? Fortunately, the side effects of these medications are usually pretty mild. The most common thing that somebody might experience would be some mild headaches, sometimes either fatigue or difficulty sleeping. But as I said, everybody feels very different during these cycles. So that's why it can sometimes be hard to counsel somebody exactly what they're going to experience. Some people go through this and actually feel great, and they feel better than their baseline. The hormone levels give them energy, they feel good. Other people are a little bit more sensitive to it. So it's something that's a little bit individualized. This is just kind of talking about the technology that we use, to freeze the eggs. This is kind of the cutting edge, the current technology that results in the best outcomes. And I always think this is just kind of a neat depiction of how this technology has advanced. In the past, we used to use what was called a slow freeze technique, where we would very slowly freeze the egg in a cryoprotectant. But that process led to this ice crystal formation, as you can see here, and that ultimately caused some injury or some damage to the eggs. So much so that when we went to thaw them, the survival rate was not that great. It was about 50 to 60% of the eggs ended up surviving. So it used to be that, we would kind of strongly recommend, if somebody had the ability to freeze embryos rather than eggs, we really would advocate for embryo freezing, because survival rate was significantly higher with embryos. Now we use what's essentially a flash freeze process, where the freezing occurs so quickly and within these different cryoprotectants that you don't get that ice crystal formation. And so it's a much gentler and safer process for the eggs, and the thaw survival is significantly higher. When we thaw frozen eggs today, the survival rates are about 90% of the eggs will survive. With embryos, it's about 98%. So still a little better with embryos, but not significant enough to say definitely you should do embryos versus eggs. There's kind of some pros and cons to both approaches. Now, the main advantage of freezing embryos is that we have more developmental information. I know how well the eggs fertilized in your individual case. I know how many embryos actually developed in your individual case. And what we'll often do is we'll even biopsy those embryos to do genetic testing. And we'll know which embryos are chromosomally normal, which ones have the chance to result in a healthy live birth in the future. So it gives us a ton of information about a specific individual or a specific couple. The disadvantage of creating embryos from a fertility preservation perspective is you're obviously, using somebody's sperm to make an embryo, and now that's, an entity that's shared or has kind of shared ownership. So when somebody's freezing eggs, obviously you have that reproductive autonomy. That egg is yours to do whatever you'd like to do in the future, no matter kind of what you decide to do, building your family, or what happens, with a particular relationship. So that's, that's the main advantage when it comes to freezing eggs. So both of those options are available for fertility preservation, and it kind of just depends on an individual person or couple what they're comfortable with. And I certainly have, plenty of couples who are married and doing fertility preservation, and they still choose to freeze eggs just from a reproductive autonomy standpoint. Or sometimes they'll split. They'll do some embryos, some eggs, and then vice versa. Some people that aren't married but will choose to, use their partner's sperm or somebody's sperm to go ahead and make embryos and freeze those for the future. Once the eggs are stored, at that point, they stay in our lab. We keep these here in our lab. We check on them every day. We don't send these to a storage facility or anything like that. And I think that's, critically important. You want your lab to have full control over the monitoring of these eggs. And these are obviously very, very precious things. And the good news is these eggs can be stored indefinitely. So there's no there's no time on, when these need to be used. So you can thaw them a month from now, a year from now, a decade from now if you wanted to, and they're going to be the same, quality egg as they were the day you froze it. And the most important, factor in terms of the success with those eggs is the quality, which is really related to the age of the egg, the age at the time of the retrieval. And that's how we, when we talk about how many eggs does somebody, want to freeze, what is a good target? It's all based on their age, which then again ties back to the quality of the eggs. So when we think about number of eggs, usually we're looking at somewhere between 20 or 30 eggs as being an ideal number. Again, in a perfect world, the more eggs, the better. If we could freeze 1,000 eggs for everybody, that's what I would want to do, because that's going to give somebody as close to 100% chance of success as possible. But it's not really realistic. Typically we're, like I said, retrieving 10, 15 eggs, sometimes a little more, sometimes a little less from an individual cycle. And so 20 to 30 is a pretty realistic goal. For somebody that's 35 years or less, 20 frozen eggs is going to give them a 90% chance at having one live birth in the future. So that's often why we target that number, because that's a pretty good success rate there. As age increases, those success rates start to decrease a bit. And that's the time where, if we can, we want to freeze some more eggs. And there's different calculators and models that I have that, when we're speaking about an individual patient, we can put, your age into a calculator and give you an idea of, based on the number of eggs you have frozen, what your success rates are. And as we're going along through treatment, that's ultimately how, we decide how many cycles somebody needs to do. We never know up front how many it's going to take. But after each cycle, we'll kind of go over how the cycle went, how many eggs were frozen. We can put that into the model and give you an idea of what your success rates are. And then, we can predict if we do another cycle and get the same number of eggs, add that to the cohort that you have, your live birth rate goes from, 50% to 80%. And then that helps somebody decide, okay, that's a pretty good jump. I think I'll go ahead. Maybe I should do another cycle. But then eventually you'll get to a point where you say, okay, I'm pretty happy with those success rates. I'm happy with what I've got frozen. Let's kind of keep those in the freezer, and then we'll come back and use those in the future when we need to. And so this is, again, just kind of talking about number of eggs to freeze, and it's very much individual based on somebody's age, somebody's goals. Occasionally we're freezing eggs for somebody that knows they need to do genetic testing on the embryos in the future. And that's a technology that we have. If there's a particular genetic mutation that somebody carries, for example, like a BRCA mutation, something that increases the risk of breast and ovarian cancer, and we know that half of that person's embryos are going to be affected with that mutation. So there are cases where we want even more eggs, because we know that, half of them, up front are going to be affected, and they're not going to be ideal for transfer. So this, again, is an individual conversation. Once somebody has frozen eggs, then at that point, they'll move forward and wait till that time where they're ready to conceive. They're ready to start building the family. And then I have the patient come back and talk to me again about where they are at that time and what their family building goals are. And it's individualized as all of these decisions are, whether to use these eggs or not at that time. I will say most people, usually up front, will save the eggs if they can. Save the eggs, first try to conceive on their own and see if they're going to be successful that way. And there's definitely patients that will freeze eggs and never need them. They'll be successful, when they're trying to conceive, and possible that they don't need the egg. So that's an important thing to know. Or better yet, that person might be successful with the first or second child, but perhaps they want to continue building the family, and as their age is increasing, that's going to be more and more difficult. So then they get to save the eggs for a second or a third child, which is just going to, again, give them a better chance at building the family that they're hoping to do. But if somebody has difficulty conceiving, or there's definitely cases where we decide, it makes sense based on their age or their partner's age to go ahead and use the eggs up front. What we do is we just take the partner's sperm, or in some cases we'll take, donor sperm if it's a single parent, and we thaw the eggs and we fertilize them with a process called ICSI, which is pretty interesting. And so I've got some pictures of that here. With ICSI, we take a look at the sperm under the microscope. There's usually millions of sperm to choose from, and we select the best quality sperm. We pick up each individual sperm, and that's what you can see right here at the tip of this needle. There's one sperm there. We'll pick that up into the needle, and then that is inserted right into the egg. And we get very good fertilization rates that way, usually about 70 to 80% on average of the eggs will fertilize successfully with this method. And then we culture embryos at that point for a week. And in the lab, we see, we set up these ideal culture conditions, and healthy, good quality embryos will continue to develop. And a lot of the abnormal ones will arrest. They'll stop growing. The ones that do continue their development after a week are the embryos that, could potentially be transferred back to the uterus in the future. The embryo transfer, of course, is the easiest part, fortunately. For that, we just take the small little catheter, deposit the embryo inside someone's uterus, not all that different from a pap smear, and then do a pregnancy test 9 days later. So that part's usually pretty straightforward. So that's pretty much everything in terms of the actual treatment itself. The last thing, I just wanted to touch on is the cost of egg freezing. Obviously, financial aspect is a big component of any sort of reproductive treatment. And, fortunately, especially in the state of New York, we see, better and better insurance coverage when it comes to not only infertility treatment, but also fertility preservation and egg freezing. So many of my patients doing egg freezing, I'd say the majority ultimately do have insurance coverage for at least part, but for most of them, all of the treatment, and often multiple cycles, which is wonderful. That's fantastic. So here at RMA, I have a financial counselor. So after I meet with the patient, my financial counselor goes through, the insurance to see, what that person's benefits are, and then we'll talk to them, exactly what is covered in their plan. If anything is not covered, they'll talk to them a little bit about what those costs look like, and then can help them kind of with any decisions that need to be made from there. So it's definitely something, if you don't know what your benefits are, that's worth looking into, and certainly we can also help you to do that. So I think that's a very, very important thing to know. And then definitely I have a lot of patients who have this benefit and they want to utilize it, and in those cases, it's usually best to go ahead and just use it, because you never know when you're going to leave your job, when these benefits might change. And so if you are somebody that has these benefits, even more so, this is something, to consider taking advantage of. So, thanks again for joining the session today. Definitely hope this was helpful for you to understand what this process is. There's a few questions here in the chat, so I'm gonna kind of get to those next. But I just wanted to make sure everybody had my contact information. This is my personal email. With my patients, I'm always very, very much available and in close contact with them, before, during, and after their cycles. So, similarly, please take my email down. If you have any questions after today, feel free to reach out. If you're looking to, do a consult, maybe check your ovarian reserve, talk a little bit more about this process, feel free to send me an email, and I'd be happy to help get you scheduled, and we could find a time, that would work. We can meet virtually or in person, kind of whatever you prefer. With RMA, just to understand, our clinic, we've been in New York for quite a long time, over 20 years now, and when you look at IVF clinic success rates, these are publicly available. We really have the best lab, I think, that you could possibly find. And so our patients here are just getting the absolute best possible care, and that's a very important thing. You want to have a good physician who obviously you trust and are comfortable with, but you want to be somewhere that has a very high quality lab that's taking care of your eggs and your embryos is very, very critical. So we have a great track record of doing that, and we are affiliated with the Mount Sinai Hospital System, and so again. The good news about this particular clinic as well is, since we've been around, for so long and have the success rates that we do, we've been fortunate enough to grow. And access to care is one of the most important things when it's coming to this kind of treatment, because you're coming into the office for these ultrasound and blood work visits, and so you want to be somewhere you can kind of easily get into the clinic. And so these are just a map of our different locations. So kind of in Manhattan, you can see, we've got an east side, west side, and lower Manhattan locations, offices in Brooklyn, and then of course, up north near Westchester, and a handful of offices out in Long Island as well. So a lot of my patients kind of live different areas of New York or travel different places for work, etc. And so for any visits, they're able to go to any of these different offices, and so it can kind of make life a lot easier during this particular process. So, okay, enough about that. Let me go ahead and pull up some of the questions that I've got here in the chat. All right, so the first question says, it's asking, we were talking about, freezing eggs, freezing embryos, and the question is, if a couple's trying to decide about splitting eggs or embryos, is that something that insurance allows, and how does that affect storage? Somebody, kind of paying double storage for that, or what does that look like? So, when we're talking about doing a split, most often we will treat each individual cycle a little bit differently. So we might do the first cycle where we decide to make embryos, and then in the second cycle, we'll decide to freeze eggs. From a timing standpoint of when eggs are being processed for evaluation and freezing, for egg freezing, versus a timing standpoint of how the eggs have to be processed in the embryology lab to fertilize them to make embryos, those processes are slightly different. And so we find that it's really best to kind of do one or the other, rather than kind of trying to do a mix, even though might be a little bit convenient, the idea of it. It's, we don't think necessarily the best thing for the quality of the eggs or for the embryos to do it that way. So usually it will be one or the other. In terms of storage, the way that our storage works is that patients just pay, they pay their one storage fee, no matter if they've got eggs or embryos or a combination. So it doesn't change anything kind of long term about storing the gametes that you have here. So it would be the same from that perspective either way. But definitely, I think your best option is to focus on one first, come to that, figure out what your goal is, however many eggs or embryos you want to freeze, and then focus on the other as well. Another question about different types of stimulation protocols. So somebody's asking whether there's, recommend something called basically it's a lower dose stimulation, so that follicle stimulating hormone. There's different doses that we give, and so they're asking if we do something called mini IVF, where we use basically a low dose protocol, specifically maybe for somebody with really high ovarian reserve, high number of eggs, PCOS. That's somebody who's at risk for ovarian hyperstimulation. And so absolutely, that's usually the ideal person for that mini IVF or that lower dose stimulation protocol. These protocols are very much individualized based on a patient's ovarian reserve, age, other demographics that we know influence how somebody responds to these medications. And so if somebody has really high reserve, lots of eggs, usually they don't need a lot of FSH. They don't need a lot of medication. So that's somebody that we would do a very gentle, stimulation and be careful because we have to worry, we have to reduce that risk of hyperstimulation. So yes, the protocol that's chosen is very specific to each individual based on their evaluation, what I think is going to give them the best success. My two main priorities are, patient's outcome and patient safety. And so we have to balance those two things when we're deciding, what their treatment protocol is going to be. Okay, another question is asking about the recommended level of activity during stimulation for egg freezing, which is a really good question. Somebody, that's very active, that likes to run, that likes to lift weights. So activity, I think, is very important, even during these treatments. Obviously, it stimulates blood flow. It's good for mental health, and all of these things, I think, are important for somebody's well-being and for their treatment outcomes. So it's definitely something that I encourage, folks to continue to be active. We do have to be a little bit cautious in terms of the types of activities during stimulation, because as the ovaries are getting larger and larger, what happens is there's a risk that ovary could twist on itself. That's called ovarian torsion. That's usually acutely painful, very painful, but requires a surgery to untwist the ovary and to fix that. So it's something that, fortunately is very, very rare, but we also try to do things to reduce that risk. So any activity where somebody's kind of bouncing around or going upside down, that's when that risk is increased, where that ovary could twist. So like I said, the stimulation is about 2 weeks. The first half of the first week or so, the ovaries aren't too big. It's very reasonable to continue doing all your normal activities at that point. The second half, those ovaries are enlarged. And so I usually tell people, you don't really want to be running anymore at that point. Anything that's controlled though, yoga, as long as you're not going upside down, weightlifting, cycling, these things are certainly fine to continue. And the most important thing is really just to listen to your body and how you feel. Once those ovaries are enlarged, you're going to feel it. You're not going to want to be running necessarily. And so a lot of it is just, knowing yourself and kind of knowing what your limits are. But definitely there's never really a point where you have to stop all activity. That's something that I would encourage you to continue. And then another question, what that process of getting the uterus ready to transfer the embryo is like, how that's different from the egg retrieval itself. So it's quite different. It's much more straightforward. Instead of doing all the injections and the frequent ultrasound, visits, usually it's about a 3-week process of taking hormones. It's an estrogen medication that's given as a pill that's taken for about 3 weeks. And then during the 3rd week of that time, you add in another hormone called progesterone. That one is given as an injection. And then after about 3 weeks, the embryo is transferred there. There's a couple of ultrasounds done during that time to, very carefully monitor again how well the uterus is responding, what those hormone levels look like. And there are some variations on the embryo transfer protocols. And again, that would be individualized and specific to each patient and their, medical and reproductive history as to what the best approach would be there. But from starting that cycle to transferring the embryo on average is about 3 weeks. Okay, another question here is, one that I commonly get is about, patients, you freeze their eggs, they're stored here in our lab, and then, you might decide to leave New York City. Obviously, that's something that we very commonly encounter. People here for a few years and then go somewhere else, and then, what's going to happen to the eggs at that point? And there's always a couple of different things, that somebody can decide to do. The eggs can stay here and we can continue to be responsible for them. And then when that person's ready to use the eggs, they can, do that embryo transfer, type monitoring that I just briefly discussed anywhere, wherever they live. We can always find a local clinic that can do the ultrasounds and send us the results. And then that person, might just fly here, for the actual embryo transfer, come for a day or two, and then, fly home. And that's the most common thing that people ultimately want to do, to keep the eggs here. But it's also possible to transfer eggs or embryos between clinics. That's something that is done as well. And one of the other benefits of our clinic here is that, we're in a large fertility network where we've got clinics all around the United States. And so it's usually pretty straightforward. If somebody needs to transfer eggs in or out of the clinic, we can do that pretty easily. So that's, I think that's important to know about. Another question here is about a patient, maybe with a history of endometriosis. They have a cyst on one of the ovaries, and they're asking about, how to handle that before an egg retrieval. If there's something that's blocking, the ovary, if we can't access it, is it something that needs to be removed, or is it something that, can stay in place? Which is a very good question specific to this situation, but it's something that very much depends on the size of the cyst and the location of the cyst. There are definitely times where I would recommend leaving that cyst in place and going forward with the egg retrieval, as long as that ovary can be accessed, as long as those follicles can be accessed. Because when somebody has surgery to remove cysts on the ovaries, a lot of times that can damage the ovarian reserve, that can quickly reduce the number of eggs there. So if they have surgery first, and then we do the stimulation, we're not getting as good of a response or as many eggs as if we had done it, prior to the surgery itself. There are other situations where those cysts can be so large that they completely obstruct the ovary in a way that it can't be accessed with that needle, and the eggs just can't be retrieved safely. And in those cases, then we would talk more about that, but that would be a case where I would refer you to an expert, pelvic surgeon who does endometriosis surgery every day, and we would talk to them about trying to remove this cyst in as gentle of a way as possible to reduce that risk of affecting the ovarian reserve, getting that ovary back to a location where we could retrieve it, and then doing the stimulation. So there are definitely times where both options are very reasonable. I'd say most often we would leave the cyst in place and go forward with the retrieval. This is a very good question about being on contraception before a stimulation cycle. Somebody that might be on a birth control pill, or another example, somebody with an IUD in place that wants to go forward with egg freezing, with fertility preservation. The first thing to do is check that ovarian reserve, see how many eggs there are. And what can happen sometimes with the birth control pill is it can suppress the follicles, or it can suppress the egg count a little bit. If we check the ovarian reserve and it looks very good for somebody's age, or above average for somebody's age, then there's no concerns at all with being on the birth control pill, in which case it actually helps to time, when we do the treatment cycle. In those cases, we can just stop the pill a few days later, start the stimulation. And then when you get your period after the retrieval, you can go right back on the birth control pill. So that's kind of the easiest scenario. If somebody has an IUD in place, it's a more of a local hormone release, so we don't really see that impact on the ovarian reserve with an IUD. So most often IUDs, we just leave those in, or any kind of long-acting contraceptive methods, we'll just leave those in during the stimulation itself. The caveat to all that is if somebody has ovarian reserve testing and that's found to be on the lower side, those are the cases where I usually recommend stopping the birth control pill, or occasionally stopping another type of contraceptive, and then waiting about 2 months. That's when you're going to see kind of the maximal rebound in terms of the number of follicles there. And with the birth control, it's about a 25% reduction, that we see. So it's not usually that the AMH is going to double when somebody stops the pill, but if it's on the lower side, even a 25% increase could be significant enough, to end up getting a few more eggs at the time of the retrieval. So when should you stop it before the process? Somewhere between just a few days to a couple of months, depending on the ovarian reserve. Okay, well, I think those are all of the questions that I got in the chat, and a lot of those were, like I said, were excellent questions. Appreciate you asking those, because those are some important things that I definitely didn't get into in the talk today. So thanks again to everybody for joining, and I hope you found this helpful. I hope this was useful for you. Again, I'm Dr. Romanski. You have, my contact information, my email address. So feel free to reach out after the talk today if you have any follow-up questions. You want to find a time to meet to talk more about any specific situation that you have. I would be, more than happy to do that. So thanks again. I hope everybody has a great night. All right. Bye-bye.